Και θα περάσουμε στον τελευταίο μιλητή από την Μεγάλη Βρετανία, τον κύριο Αποστόλη Καρκανέβατο. Είναι διευθυντής στο νοσοκομείο Mid-Cheshire Hospital. Διευθυντής, είπαμε, τμήματος οτορινolaryngολογίας και πλαστικής χειρουργικής προσώπου. Κύριε Καρκανέβατε, έχετε το λόγο.
Γεια σας. I apologize. I will speak in English. I don't know. Can you hear me and can you see my screen?
Yes.
Okay. Again, I would also like to give my thanks to Tim and Yorgos. I'm really privileged to join your webinar. I was planning to come to Greece, but I didn't manage. So I will go ahead. Let me sign. So augmentation rhinoplasty is my talk. Augment means make it bigger. My point here is that historically, the first rhinoplasty procedures were augmentation rhinoplasties. The bulk of my work is actually that on the right, but there is a spectrum in augmentation rhinoplasty from a really tiny supratip depression following septoplasty to a massive SCC requiring massive reconstruction. Now, as I said, the first rhinoplasties were augmentation rhinoplasties is infiltrate with BCC, excising with a forehead flap, the Indian flap described 2,500 years ago, 3 months down the line. An SCC with a big hole there, you have to fill with mucosa, cartilage, bring the skin down. This is only 2 weeks following the excision. But this is a talk for another day. So today I will stick to more cosmetic and less tumor surgery. So these will be the kind of procedures, following septorhinoplasty. This is a baseball trauma, horse riding accident, domestic abuse with asymmetry, and cocaine. So as we already seen, the bulk of augmentation rhinoplasty is due to trauma, surgery, and some cocaine and inflammatory conditions. We're not going to talk about tumors. And in the Western world, there aren't many congenital augmentation rhinoplasties. If you go to Asia, the bulk of rhinoplasty will be augmentation rhinoplasty because they want a 3D nose as opposed to 2D nose. Now, because of that, quite often the patients have more reasonable expectations, but not always. So the grafts, we already discussed grafts. I have never used a synthetic graft, but I have taken out quite a few different grafts that have been used over the years by different surgeons, but I have only used bone, cartilage, and permacol. So bone graft, it's only a handful of procedures that I've done. Surprisingly, they were all pretty successful, actually, very good outcome. And only one patient complained of the rigidity of the middle third. You can harvest the inferior turbinate, the bone. The important bit is to use the drill to make sure that the whole mucosa is off the bone. You carve it, and you can. It's not good for the lower third, but for the middle third can work pretty well. But as we know, we do have better options. So one thing I'm not sure if you are using it in Greece is permacol. I think Filio has presented and written about it. I have used it for 15, 20 years without any significant problems. So it is porcine pig's collagen. It comes in 3 by 3.5 millimeters, quite thin, but also 1.5, 2 different thicknesses. You can cut it into shape. You can suture it. It's it's very, very useful in a number of procedures. You can use it to augment, you can use it as a filler. But the main grafts in augmentation rhinoplasty, as we've already heard, are grafts, septal cartilage. Previous speakers have already mentioned the L shape, auricular cartilage. You can take quite a lot of cartilage without damaging the shape of the pinna, and costal cartilage. I mean, for the last 10 to 12 years, I haven't harvested costal cartilage. I can show you in a little while. You can get cadaveric cartilage. So this is post-septoplasty by another surgeon. I tried to convince the patient that it wasn't that much of a problem, but he insisted that he wanted that fixed. So you can do an open approach and use spreader grafts, but you can also just make a small intercartilaginous incision, just limited pocket, use septal cartilage, sculpture the graft. You can score for contouring. So if you have a flat graft, you can score it and make it fit the defect. And if you actually have a limit pocket, you don't need any sutures, but sometimes you do have to put an absorbable stabilization suture. You bring it out on the dorsum, and you just push the scissors when you take the steri-strips off, and you cut, and that's it. So this is a very gentle gentleman, actually, but he was a street fighter. He was a gypsy, and he had multiple injuries. You can see the asymmetry. He had significant septal deviation to the left. He couldn't breathe through the left side. So you can do a marginal incision, but I did an open approach, and you can actually put a filler there, but you can also flip trim the lateral lower lateral cartilage. So you dissect it, you flip it. You have to obviously trim it, and that was my mistake, I think, because I didn't overlap like the previous Kypriou showed before. So initially it looks okay, some asymmetry obviously remains, but then he kept on fighting. So after a year, you can see a little bit of a notch. So I would strongly, I didn't have enough cartilage, but I would strongly suggest to overlap the cartilage. It's safer, especially if there is repeated trauma. So this is post-septal rhinoplasty with a classic V deformity. So the question here, if that is a true hump or a pseudo hump, I wasn't even sure, but the patient insisted, and she was right, that it was a true hump. So she needed dehumping osteotomies. Again, no spreader grafts, just a little bit of permacal. So you can see the V deformity fixed, and this is 8 years down the line. She came back for hearing aids. So this is a more complex trauma. It's baseball bat on the face. So you can see with the color change where the nasal bones are. And obviously a huge defect there, lots of scarring. You go there and you have lots of cartilages. So it needed auricular cartilage, console cartilage, osteotomies to narrow the bridge, obviously, septal extension grafts, spreader grafts, and 2 or 3 layers of permacal. You have to secure the tip and leave the splints for twice, 12 to 14 days rather than a week. I never ever had problems with harvesting auricular cartilage. So then you provide a stronger nose. This is a year down the line, and he had another fight, and he told me that he was aware not to damage the nose, so he turned, so he had the punch on the eye. So this is a mistake underdone, augmentation by myself, horse riding accident. This is definitely a pseudo hump. There was a lot of scarring, open approach, septal extension graft, some permacal, but I think I needed a little bit more extension at the tip and probably cephalic trim. Patient was happy. I wasn't that happy, but just it's a more balanced nose, but I think it is underdone. So just be aware. I think it had to do with the scarring. Initially, for the first 3 months, the patient told me and had photographs that it was a bit better, but then 6 months down the line, we had this result and it didn't change. So skin scarring, and then some of the patients demand to have plastic surgery to get rid of the scar. You have to tell them that this is impossible, and you have to be aware of the light reflection on the scar, domestic violence, multiple scars, deviated septum. Obviously, there was significant defect in the left lower lateral cartilage and upper lateral cartilage. Pseudo-hump. I did emphasize that she has to have realistic expectation, especially with relation to the skin. I used septal cartilage grafts, Permacol. And the point here is that you can see it on the photographs, you can see that. And this is just the skin reflection. In other angles, you wouldn't get that. You can see that the contour is okay, but the reflection somehow over there, it's not quite all right. But she was happy and she could put the makeup over the scars. Just be aware of that. Now, more challenging, this is cocaine abuse.
Άρα ακούγομαι, έχουμε 1 λεπτό για την ολοκλήρωση της εισήγησής σας.
Ευχαριστώ. So large septal perforation, total absence of quadrilateral cartilage and upper lateral cartilage, severe inverted V deformity. You can see the severe scarring. She hadn't had any photographs for 4 years because she was embarrassed. You can see the big step there. Let me see if we can play that. So no quadrilateral cartilage and chronic rhinitis. We can try and move. I was worried that there wouldn't be enough soft tissue. You can see the defect. So this is what I used for the last 10 years, is cadaveric. I hadn't had any significant warping or any problems. One of the problems might be size, especially in males. So you have to carve it. There are 2 different ways of doing these. Either I needed a wide graft there because there was nothing in the middle nose. So you use either a columella strut stroke septal extension graft. And this is a year down the line. So we shouldn't underestimate the psychological background. A lot of these patients are embarrassed by the nose, by their injury. Be aware of scars, balanced approach. And obviously, because you're putting stuff there, there is an increased risk of delayed graft. So make sure that you stabilize everything for long-term efficiency and effect. Thank you.
Ευχαριστούμε τον κύριο Καρκανέβατο για την παρουσίασή του.